All right, welcome, folks. Thanks for joining us. We're very excited to be resuming our e-learning events after taking a break over the summertime. And we're coming back with some very excellent presenters and presentations lined up for our fall series, where we're celebrating community-based research excellence. So in this series, we're highlighting the winners and the runner-ups of our Community-Based Research Excellence Awards. So to kick off our series with a strong start, we are celebrating the winner of the 2025 Community Campus Partnership Award, the National Overdose Response Service. So this is a research project, a initiative that was formed out of partnership between Dr. Monty Ghosh from the University of Calgary and University of Alberta, as well as Greenfell Ministries, a nonprofit in that area. So we'll be highlighting this project throughout our event today as the first event in our series of highlighting community-based research excellence this fall. As I get started today, I just want to let folks know that if you would like closed captioning or if you'd like translated captions, these are both options for you. You can see the instructions on the screen now if you would like to enable your captions. If you'd like to translate your captions into another language, you are able to do that as well. And I'd also like to acknowledge as we get started, the Community-Based Research Canada Secretariat operates from the traditional territory of the Anishinaabe, Haudenosaunee, and Attawandaron, or neutral peoples. Our office is located on the Wilfrid Laurier University campus in Waterloo, Ontario, and this is situated on the Haldimand Tract. The Haldimand Tract includes 6 miles on either side of the Grand River, and this unceded land was promised to the Six Nations of the Grand River in the Haldimand Treaty of 1784. We give thanks for the privilege to work and live on this land known as Waterloo, Ontario. At CBR Canada, we're committed to building relationships with First Nations, Métis, and Inuit peoples across Turtle Island and to promoting research projects and approaches that actively work towards reconciliation. We recognize in community-based research that it's important to embrace different knowledge systems and ways of knowing, and Indigenous knowledge and research as being one way of doing things that we embrace here. If you're not familiar with Community-Based Research Canada, we're a membership-based organization with a mission of advancing community-based research excellence in Canada by strengthening partnerships, building capacity, mobilizing knowledge, and championing community-based research. We are a social enterprise. We have no core funding to do what we do. We're funded by our members, over 70 institutional and organizational members, as well as individual members. And part of the programming we provide are events like today, our e-learning events, as well as a community of practice that we host and a variety of other programming offerings. You can find these on our website, which our volunteer for today, Chimram Emieka, has just posted in the chat for you. So my name is Amanda Demmer. I'm the Program Coordinator and Learning Specialist for Community-Based Research Canada and your facilitator for our event here today. And joining me, Chimram Emieka is a volunteer with CBR Canada who will be supporting the event, and you'll see her sharing some links and other things in the chat throughout the event. Our agenda for today, after I'm done this very brief opening, I'll pass things over to our presenter for today, who will share with us about the National Overdose Response Service. Following the presentation, we will have a question and answer period. I do encourage you, if you have questions, to answer them, or sorry, to ask them in the chat box at any time throughout the presentation today. We'll be monitoring the chat, and when we see your questions come in, I'll store them away so that when we get to the question and answer period, we'll start with asking those questions. So please, again, feel free to ask questions at any time in the chat box today, and we'll address those questions when we get to the question and answer period. After we wrap that up, we'll have a brief closing. We'll tell you about our next event, and we will wrap up our session. So without further ado, I would like to welcome Dr. Monty Ghosh, a clinician scientist at the University of Calgary and University of Alberta, who's here to present today. I'd also like to acknowledge Lisa Morris-Miller, the CEO of Greenfield Ministries, who's been pivotal in this project, but unfortunately was unable to join to co-present with Dr. Ghosh today. So, Monty, please take it away.
No, thank you so much, Amanda, for having me here and being able to speak to you guys today. As Amanda mentioned, Lisa's not here today. I have her picture right here, if you guys can see it, with us together. She is on what she calls the prison tour. So she is right now going to all the correctional facilities in Ontario, talking about NORS. And unfortunately, one of the sessions of these prison engagements is happening at this very moment. So she's not allowed to bring her phone in there. Uh, she's doing her presentation with stuff that they already have inside of these corrections facilities, and so she couldn't be with us today, else she would have been here to join us. But it's our ongoing joke. She's on our prison tour 2025. And so this is Lisa right here again. She's our brave CEO on the far right hand side, with a picture of Justin Trudeau on her shirt. But this is the team, and this is really the secret sauce of NORS. So these are all our operators, who have been operating the line, supporting people who use substances while they're using alone. And that's sort of again, these people are the people who form connections with the callers. These are the individuals who support them through their substance use. And for some of them, these are the people that get them into recovery. They're there for them for whatever they need. And so I just want to really acknowledge these individuals here. Before we move forward, I do also want to state that I am working off of Treaty 6 and Treaty 7 territories here in Alberta. Specifically, right now I'm in Treaty 6 territory in Edmonton. But yeah, we're again grateful to have this program be cross Canada wide, on Turtle Island. So grateful again for this opportunity in the land that we are on. So a bit of background, and this is more sciencey, and I wish Lisa was here to kind of give you the other side of things, which is a bit more operations, but also how we work together. Because I'm a scientist, I'm a researcher, I'm a physician in Edmonton, and Lisa is our frontline CEO, person who's working on the ground, interacting with clients. As I said, she's actually in the prisons right now, talking about NORS and helping them with their transitions outside of corrections. And it's an interesting dynamic between the two of us, because I have to learn what she does and she has to learn what I do, and we have to kind of come together to figure out how to evaluate this program. And it's really been a partnership that has been so helpful for both of us, and myself especially. Like she's been with us through thick and thin, and we've had a lot of issues in our time in terms of dealing with funding, trying to get ongoing funding, getting concerns from community members because of the sensitivity around what we're doing, which I'll talk about in just a bit. But Lisa has sort of been, at least for myself, my rock through a lot of this, and so I really do want to acknowledge her, and that can speak to some of our dynamics if that does come up later on in questions, in terms of how to work with community as an academic, as part of like myself being part of the University of Alberta. So a bit of background. I am also an addiction physician and internal medicine specialist, so I deal with people who use substances all the time. And what we do know is that 60 to even up to 80% of people who are dying of drug poisoning events or opioid toxicities are dying in their own homes while they're using alone. And NORS was really developed for them. And so we do know that in terms of good news is that opioid overdoses can be reversed using naloxone. So we do have an antidote for this. And we also know that supervised consumption sites reduce mortality, but they have a geographic limitation. So that geographic limitation in terms of how they can reduce overdoses is within a 500-meter radius around them. People, and up to a kilometer, people are not willing to walk more than that to get to a supervised consumption site. Of course, they can't drive, right? If you're using your substance and you're intoxicated. So there is a limitation in terms of how broad these interventions can go. So NORS was created for them. And what NORS is the phone line. So if you're using drugs alone, you call the line and you get connected to a peer. And that's one of those numerous faces you saw in the very beginning. And they're on the phone with these individuals, answering questions, being there for them. And they ask them a few key things. They ask them to unlock their front door, turn on the porch light if they have a porch light, hide their pets, store their supplies away if they need to, if in case they do need to get resuscitated. And then also potentially have a carry away bag. And what I mean by that, and it's a genius idea that they came up with, is that sometimes when they get whisked away in an ambulance to a hospital because they're unconscious, it's cold, it's winter time, they don't have a winter jacket, they don't have toiletries. So they have this takeaway bag, if you may, that has it all ready for them that they can leave with. It has a little sign or sticker on saying, please take me before you leave. Anyway, if they are at any point in time unresponsive, we enact a tailor-made response for them. This response could be EMS, which it often is, but this response could also be calling someone who's nearby, calling a loved one. If they're in a harm reduction housing facility, it could be calling a receptionist in the front desk who also has a Narcan kit. It could be calling the person's mother who might be in the same home as them, which we've seen before as well. So it's really a response that's tailor-made for them. And then, and yeah, we either dispatch EMS services or we get a family member or community support person to help support them. So who uses this line? People use substances alone. We are able to provide the service in both English and French, and we're geared towards all types of communities, whether urban communities, suburban communities, and rural communities. We really, because of the high rates of deaths amongst the construction community and blue collar community, we are really focused on them a lot as well. And of course, our Indigenous communities. But there's also some indirect benefits as well. So for first and foremost, for example, for myself as a frontline provider, often all I could do was provide an naloxone kit if someone's using alone and say, please don't use alone, please use someone else. But I now have another tool to use. I can say, please don't use alone, please use this phone line. We also have a bunch of community agencies who support individuals who use substances who benefit from this. And we've heard from others, from family members especially, that they really appreciate the service because it's something they can offer their family member too to make sure that they stay safe while they're using substances. And we're also tailored towards a large portion of the population who do have access to phones, but who do use alone. And so this was just an epidemiological study that was done through the CCSA, the Canadian Center of Substance Abuse Addictions, where they looked at and predicted how many people are using non-medical opioids in Canada. And of those, 13% have access to supervised consumption service. And of that population, about 6% of them have phones, which means that there's about 100,000 individuals who have phones and don't access SES. And that is our target population that we're going for. That's the population that we're really hoping to support and serve based off of these studies that have been done in the past. So barriers for this service. Barriers that the service removes, I should say. First and foremost, there's geographic distance barriers that this takes care of. We know a lot of our callers do not want to be seen at a physical supervised consumption site. And a lot of our callers are professionals. We have professional athletes who call the line. We've got physicians who call the line. We've got people in the business sector, in the not-for-profit sector, all over the place who use the service who we wouldn't classically think of as substance users, which goes to show that there's a large hidden population of substance use that we don't engage with. There's also time barriers for the service. So, for example, a lot of the services in the SESs, Edmonton can be an example of that, are not 24/7. They're not open 24/7. And so we have a lot of individuals who call after hours. And there's also limited mandates around SESs for some of them. So for example, we only have 2 SESs in the entire country that provide inhalational support for substance use. And so this provides an avenue for them to stay safe as well. So while there's barriers that the service removes, there's also limitations of the service as well. So one of our big concerns is that people might be drowsy but are not overdosing. So we might have to dispatch EMS services if they do not respond to our prompts. In some jurisdictions of the country, police may come to the call out, and this may be problematic because they might have a warrant for their arrest or the client might have children. So the Good Samaritan Act is there to protect individuals, but if you have a warrant for your arrest or you have children on site, Good Samaritan Act may not protect you. Your paraphernalia and your supplies might be confiscated by police services if they respond. And then some people might overdose very, very quickly, and EMS services may not arrive in time, especially in rural communities. It's for these scenarios that we really want to enact our community-based responses, of course, so that we can contact a person nearby who can help support the individual if they need. And over the years, NORS has expanded to do more than just overdose response. They provide peer-to-peer support. They provide mental health first aid and mental health supports as well. They do psychosis de-escalation for people who are using crystal meth and are in acute psychosis to make sure that they stay safe. There's other things that they do as well. We recently started doing more case management. We're providing support for people coming out of corrections, which is why Lisa is in corrections today, to help sort of gather some information, share with them the program. We're supporting people coming out of acute care sites, treatment facilities. We know that these transition points are very vulnerable points for these individuals where there's a high risk of relapse, and this service is there for them. So this is some data that we have. This is from a paper that we published back in 2023, and this is over 2 years of data. We've got a lot more data now, but we had received over 8,000 phone calls from 591 unique users. Most of the phone calls were for supervised consumption services. Some were for mental health supports, and there's some for information resources and other reasons as well. But the vast majority of our callers were calling from Ontario. Things have shifted now. I would say about a third of our calls are coming from Ontario. Our volume of calls has also increased drastically as well. But we're getting a lot more calls coming in from BC, from Alberta, from Saskatchewan, and so now the numbers are a bit skewed, of course, from this. So Ontario is about 30% now still, but a good chunk of our calls are still coming from Ontario. And as you can see here, the vast majority of our calls are around overdoses. And so we've had 162 overdoses between December 2020 and December 2024, so a little more up-to-date data. We've had lots of SES calls. We also provide some mental health calls as well. The big thing to note is that we've had 0 fatalities so far, and this has maintained itself to this date. That was, I think, the biggest fear when we first got started. We got told over and over again that who takes on the liability if someone passes away, we will get sued. The other big concern was that we're going to have tons of EMS callouts and false callouts, which I'll show you the data for in just a bit. But thus far, we've had 0 deaths on the line. We've had lots of adverse mental health outcomes as well. So we are providing support for people who have suicidal ideation, who are in acute psychosis, who need help. We've been able to get EMS to their homes to support them. And so we've done a lot of work around this area too. And we're not supposed to be a substitute for things like the distress center, for example, or the crisis hotline. But what's interesting is that a lot of these hotlines don't deal with substance use. And so therefore we are providing support in a niche area where you have concurrent mental health and substance use concerns. We know from epidemiology that 80% of the population who has a mental health concern also has a substance use concern, and vice versa. So there's a whole swath of individuals who are not allowed to access these other services, which we're providing support around. We have a large portion of individuals who use our line who are Indigenous and have an Indigenous backgrounds, as you can see here. I would say about a quarter of our phone calls are coming from people who identify themselves as being Indigenous. And the other unique thing is that a large portion of our callers are gender minorities. So as you can see here, about 75%, about a quarter of our callers identifies either being women or gender diverse. This is an exact opposite to what we see at physical supervised consumption sites. So at physical supervised consumption sites, about 80% of the people who use those sites are people who identify as men. So this is a very, again, a unique niche that we're kind of covering. That is different than what we see at supervised consumption services. I kind of showed a higher number before, but this is a bit of an older data set, but 7.1% of callers report they are Indigenous, or most are First Nations and Métis, and they come from a variety of communities all across Canada. And in terms of community type, a lot of our callers are calling from urban areas. That's the vast majority of our calls. But 5% about 8% are calling from, I take that back, sorry, 3% are calling from rural communities and smaller communities. The vast majority of substances that are being used are opioids, and the biggest route of use is injection, followed by smoking. And so we, again, provide support for all routes of use, which is another key barrier that we take care of that doesn't necessarily exist in most SESs. And what we've noticed with some of our data, and we were able to publish this in the Lancet Americas, was that a lot of our callers don't have access to an SES at certain times and certain points. So as you can see here, a good portion of our callers can't call because there's no SES in their location, or if they do have an SES location, it's not supporting their use of call, or sometimes it doesn't support the hours that they've been using their substances for. And so 60% of our callers had no possible SES options, and 12% had moments when NORS was their only option, even if they had an SES, to use to use safely. So again, we're providing a great service for people who are very, very vulnerable. And this is kind of the breakdown from province in terms of our callers and whether or not they had access to SESs. And as you can see here with the red color, that a lot of people don't have access to physical supervised consumption sites in their province. Saskatchewan, for example, is there, Newfoundland, Prince Edward Island. So we do provide support for those individuals. And so here you can see, again, the breakdown in terms of phone calls at nighttime. As you can see here, between midnight and 6 a.m., we have a large number of phone calls that are happening from our clients who don't have access to an SES at all. So some of our health outcomes. Again, our data is all over the place because we have different timelines in which we gather the data and we share the data. But thus far, we've had, I think, over 200 overdose events, 0 deaths. We've had numerous phone calls. We've had over 30,000 phone calls, no fatalities to date, as I mentioned, and we've had about 5 false alarms. It says 3 there for that time period, but we're about 5 right now. This was another key concern from EMS services, is that there was a lot of worry that we would have a large amount of false callouts, but that has not happened, and we've been measuring it. So some unexpected uses of NORS is that we're the only national peer support hotline and service. So that's supporting people with lived experience, supporting other people with lived experience. We're the only psychosis de-escalation service in North America, I think, especially for methamphetamines. We also provide a lot of naloxone training for people in rural communities because we are worried that EMS may not show up on time. And so we want to make sure that communities who are, especially in small communities, have the ability to respond to their own overdose events. And we also provide a mailing service for sterile supplies and naloxone kits across the country as a mail out harm reduction service. This is some of our mental health outcomes. So this is from December 2020 to April 2023. Most of our mental health emergencies were responded by our NORS staff. 9 incidences were handled by other incidences were handled as well. So this could include wound care, fires, home invasions, domestic issues. 7% of cases were also occurred where NORS had to actually call poison control. So we often get calls around people who might have consumed prescription drugs and they think we're poison control. We're not. We're the poison center, so we actually have to refer them on to the poison center. So one of the big things that Lisa and I have done is because of the stigma around harm reduction and because of the concerns that were placed on the service, we've worked really hard in partnership to make sure we build robust evidence for the service. So this includes data tracking, presenting the data, publishing as much as possible, doing a mixed methods approach to publishing or to evaluating the program. So we used what was called, we used an implementation science model, Proctor's framework specifically, to evaluate. So this is mixed qualitative and quantitative data. So we look at interviews with clients, but we also do surveys with clients, but we also look at outcome data and outcome measures, which you've seen already today. But it also includes a cost benefit analysis and cost effectiveness analysis, which we've also done too. So this is our cost benefit analysis. And as you can see here, and we need to update this data because it's a bit outdated now. And we've got so many more phone calls and the ratio of phone calls to our operators is a lot higher now. And the ratio of our calls to our operations costs is much more high now. So the cost benefit ratio is a lot higher, but for every dollar that we've invested in NORS, we got back about 8.59 in return. And this number has been sort of gathered from costs of overdose events, EMS costs, the cost of the naloxone kit administered, the cost of life lost. So we've really gone through the data to kind of determine what our cost benefit analysis would be. And then we were using very conservative numbers around this. But if the bottom line number is about $1.53 for every dollar you put into the program, but the higher dollar value is about $15 per dollar spent. Our community response was about 34 times more cost effective than our EMS response. And then we did what's called a Monte Carlo simulation. So if 45% of individuals who had a mortality event from an unmissed overdose, their return on investment is about 8.59 per dollar invested. So since NORS launched, we also did a social return investment evaluation, and we found that for every dollar invested, there's about a 19.15 cent return. So that's amazing numbers. These are all numbers we have to present to Health Canada, for instance, to get our funding going. And we have a cost effectiveness analysis. I don't have a slide for that right now, but that's hopefully going to be published soon to again show the benefit of the program and how it affects the system as a whole. As of November 2023, we've also moved on to texting. And so we had a soft summer launch to test it. There was a lot of hesitancy with this. And talking to Lisa and the operators, they share their stories. They're like, you know what? Over the phone, we're just using two of our senses, our ability to listen and our ability to talk to a person. With texting, you lose that ability to hear what's going on behind the scenes, and you're really relying on just one sense to figure out if they're going to have an overdose event or not. And thus far, it's been really successful. We've been able to engage with individuals via text. Essentially, what's going on is that they text us and we ask them to send any sort of text back within 1 minute. It can be an emoji, it could be gibberish, it can be whatever. They just have to reply every minute. We check in with them. And so far it's been working. We've seen a lot of increased uptake, especially in the maritime provinces, which was very interesting. But it's also an avenue for people to engage with our operators and feel comfortable dealing with the operators. And so these are some of the positive texts we received from our sessions. So it's a great service. It makes it feel a bit safer, even though it's a Russian roulette every time. Someone knowing I'm using gives me a much better chance of something if something happens. Another one, I'm in the military and have roommates. I can't talk. Thank God for the service. Hey, I plan on taking a dose of fentanyl I don't know the potency of yet, or I'm familiar with, and I would like some extra security. Due to nervousness, though, I have troubles making calls. I've messaged so many people didn't respond before I found this. You are doing something great for people. I hope you know that. I appreciate the service for you and other people who do this more than I know words for. This is a lot of the feedback we've received from our text messages. So these are some references for you guys. But yeah, happy to sort of answer questions on in terms of how our partnership is and how it goes and what's about. And again, grateful for the work that Lisa and team have done. A lot of the team members are on that photo. So there's Pam, there's Shay, there's Jody. So shout outs to them as well for kind of being the drivers of this program. And yeah, again, grateful here. And also our research team too. So that shout outs to Dylan, Will, Avneet, Alice, Nathan. So we've got a great team of people who work behind the scenes, Maria, to help push things forward as well from a research end. With that, I will pause and I'm happy to answer some questions.
Thank you so much, Monty. It was so fascinating reading the original nomination for this as a nominee for our Community Campus Partnership Award, and I'm glad I got this chance to hear more about the service that you provide and some of the outcomes that it's had and the feedback you've gotten. So thank you so much for sharing that. And as we get into the question and answer period, I'm wondering if we can start just by diving in a little bit more to that partnership, like you'd said. Um, so this project was a partnership between academia and the nonprofit from Greenfield Ministries. So can you tell us a bit more about that partnership and really how community has been involved in shaping or driving either the service or the research that's been attached to it?
Yeah, so I mean, it's a constant communication dynamic, to be honest with you. A lot of our research questions comes from them themselves. They'll be like, "Hey, what's going on here? What's the answer to this?" And it goes from my end as well to them. It's an interesting dynamic because it's been a dynamic of survival, to be honest. I don't know if that's different for. I feel like that's different for a lot of projects. We are so worried about our funding getting cut. We're so worried about the stigma and the opposition to harm reduction. Uh, we're worried that, and we've heard rumors that governments don't like us, that we'll get shut down. We had an Alberta project that got shut down, which is how I got in touch with Lisa's sisters. Actually, I need to give a shout out to Rebecca Morris Miller. I failed to do that in the very beginning, and I should have done that. And Rebecca Morris Miller was the person who started the NORS line. That was Lisa's sister. And when our Alberta line got shut down, it was Rebecca and Kim who got us together. Kim was Rebecca's friend and also one of the previous leads for the NORS program, who got us together, and we were able to launch a national line to overcome the government of Alberta's opposition to the phone line.
Mhm.
And but there was always these constant threats of us getting shut down, because the Alberta government had concerns about the Alberta line. They shut the Alberta line down. We weren't even operational with the Alberta line. We are about to launch. We had $1 million grant in Alberta to get a line launched that was very similar, and 8 hours before launch, it got shut down. But
Mhm.
for us, it's been a partnership of survival in some respects, because from my physician, public health, research lens, uh, we know that in order to keep things moving from a healthcare perspective, you need to have evidence and build the evidence around it. Um, and from the community lens, from Lisa's lens, and from people who use the services lens, they need a service to keep going, and they need a service that helps, support them and keep their lives, like, for them to stay alive. So
Mhm.
I mean, it became a dynamic of survival for us to partner together to make sure that the line survives, and to be as unbiased as possible. I know sometimes as a researcher, if we're trying to keep something alive, there's a risk of bias, but we've really tried to avoid that. We've tried to make sure that everything was independently reviewed, tried to make sure we were as robust and truthful about our evidence as possible, not try to oversell things, because sometimes, we run the risk of overselling ourselves just to get money, and that is not what we want to do. We want to show that there's benefit, but also realistic benefit, and also know what the problems are with the service. That was the other part of our evaluation too, because there could be serious problems with it. There's no doubt in my mind that, and it's not a perfect service by any means. We are not reaching everyone and everybody, and we're not a perfect service for a lot of people. But it's making sure that we're able to evaluate that to be the best we can be, and that's been the dynamic between NORS and the universities, that we've really tried to work together. And it's not as if we don't butt heads sometimes. It's like sometimes we need to evaluate something and we're like, we want to do this, we want to do that. That's not possible. You need to be mindful of your language, Monty, in terms of how you're approaching people's lived experience. You need to talk their talk sometimes as well. And so it's a great dynamic, because then they'll also review our surveys. They'll review our language that we use. They'll do the surveys themselves and say, hey, you know what, we will make sure that this gets taken care of. Trust us, because we're people lived experience and we know what we're doing, and they do know what they're doing. And so yeah, that's kind of the dynamic. I often take my lead from them, more
Yeah.
often than not.
Yeah. You touched on, I think, some really key elements of excellence in community-based research in that. You said earlier in the presentation, one of the things you had said was just, you're always learning from Lisa and she's always learning from you. And that aspect of kind of reciprocal learning is something that's such a key element of good community-based research is, as researchers, we have to learn from the communities just as much as we might also be trying to teach the communities how to be part of a research process. And I think you captured that really well. And the way you spoke there as well to, taking the example of the community, letting them take the lead, um, not, formalizing any of your research tools before that lived experience lens has been there to look it over and say, yes, this makes sense. And you also spoke, I think, really well to this delicate balance we play in community-based research of the research needs to be relevant to the community, driven by community, but it still needs to have these standards of academic rigor and excellence. And you spoke to that, we're not going to compromise that academic rigor just to get the results that we want. And that can be a really delicate balance in community-based research to serve the community well while still having that academic rigor. So that was great to hear you speak to that as well. Mm. So if folks have questions, please feel free to put them in the chat box. And I see the comment. Yeah, the text messages are examples that the service is valued. That was really great for you to share those and to hear those, Monty. Um, I'm wondering, so you spoke there about, the dynamic of the partnership now. How did the partnership first come to be? It sounds like this NORS service, it started as something that was very grassroots. So tell us how they came to seek you out, how you came to become this campus community partnership.
Yeah. It kind of, so there's about 3 different projects that were kind of trickling all at the same time. So in BC, they had this group called Lifeguard. Sorry, not Lifeguard. What am I talking about? Brave. Brave. And Brave was working on a phone line, not a phone line, I should say. It was an app that helped with overdose responses. So it was an app. In Alberta, we were working on a phone line, and for myself in particular, the concept came from a patient of mine. So he lived in Grand Prairie, which is 3 hours north of Edmonton. And I was talking to him over the phone. I'm like, you're using drugs, or using alone. Do you have an naloxone kit? And he's like, I kind of use alone and kind of don't. When I probed on him a bit more, he was like, well, I FaceTime my buddy in Edmonton. We use together. I'm like, interesting. I'm like, well, what happens if one of you overdoses? He's like, well, we just call EMS. We have each other's address. So
Mm,
like they came up with their own idea, and it was a genius idea that we tried to industrialize in Alberta. So we got a grant, we tried to create a phone line of our own. And it just didn't work out, of course,
mm,
because of some concerns. Um, Lisa, sorry, Rebecca Morris Miller and Kim in Ontario came up with a similar line and similar concept and launched theirs. So it took us in Alberta 3 years to launch our phone line before it even got launched. It didn't even get launched, to be honest with you. Like 8 hours after 3 years of work, got shut down. They got their line up and running within 3 months, no
mm,
issues. And it's because they didn't necessarily have to go through all the rigor of our health authority.
mhm,
And which goes to show how powerful community can be compared to the rigors of of the healthcare system.
mhm,
And so we saw their name on a newspaper, and then I called them. I Googled Rebecca's name, and I tried to figure out who she was, and we were able to get in touch with her, and then that's how the partnership formed. And then when our Alberta line got shut down, Rebecca called back and was like, you guys got a problem, how can we help you?
mm,
And so then Rebecca helped us out, and she got the line up and running. We made a national line out of it. Unfortunately, Rebecca passed away on Halloween 2022. And so that was very hard for us. And so it goes to show the stigma of substance use. She was using, she had relapsed, and she was using, and she unfortunately didn't wake up. And so Lisa's since taken the mantle of the lead, but that's how the service and the partnership got started.
mhm.
And it's been a learning experience, and it's been probably one of the biggest experiences I've had in my life, is working,
Yeah.
learning from them. And it's really changed me as a researcher. I've learned so much from them. Honestly, it's been the best.
Mhm. What I really love about that story, I mean, coming from the public health sphere myself as well, when we think about like health innovation and some of the big things that really change health systems, it the things that most have impact usually come from the patients themselves, the folks who have the lived experience, right? It's not the researchers that are going to come up with that brilliant idea. And that's what you said, that story of, it was a patient with yours who just had this mechanism they came up with to keep themselves and their friends safe. And it's like, hey, this is a brilliant idea. And folks who have this lived experience came up with this themselves as something that works. So how can we roll with this? How can we build a project based on this instead of, that researcher imposition of ideas that may not work in the real context? And that's often how community-based research comes to be, is research ideas come from the community, or new innovations come from the community, and we look at how we can then partner and run with those ideas. So thank you for sharing that. That's really neat to hear. Hmm. I see there's a question that came in the chat here. Jenny has asked, have your services shifted at all with the rise of benzos in the street supply?
Yeah. So a really good question, Jenny. Lots of benzos and xylazine and other contaminants in this, the drug supply, carfentanil. We're seeing a lot in Edmonton right now with carfentanil, but it hasn't shifted at all for that. We're still on the phone with them. We still support them. We still dispatch EMS services to support them. So that part has not shifted one bit with us. It's business as usual. And it definitely makes us worry for sure, but be a bit more cautious. But we haven't tailored anything towards those specific issues. We are sending out testing kits though, so that's one of the things that we're doing, is we're sending out testing kits, benzodiazepine testing kits, as mail out kits to get people to test their stuff. But
Mm.
Hasn't shifted as of yet. I'm certain it may in the future, but fortunately, we've been doing okay. Jay
Mm.
says I see a lot more folks who are unconscious for longer around here, and that's why I asked. That's fair. Jenny, would you want to share some of your stuff or your story or where you work if you feel comfortable?
What we can do as well, because we do record these events and we have a recording going right now. If there's any other questions, we can address those and then perhaps even stop the recording. We're a small group today, so if we want to have some candid conversation when the recording stops, we can do that. Yeah. So do any other folks have questions for Monty before we start wrapping up today?
I do have one question, Monty.
Yeah, please.
Um, so earlier on in the presentation, you talked about how like there's a difference in the gender of those who have called versus those that access in-person SCS services. So I wanted to know, like, if you have any thoughts, like, or any reason, any speculations as to why that might be happening.
Absolutely, yeah. We did a qualitative evaluation around this, and essentially what we found talking to the women who are using the line, as also other women who are using SES, is that many of them don't feel safe necessarily in a physical SES. They many of them work in the sex trade and they're very busy as well. The other big thing is kids. Many of them have children and they can't leave their parental duties, and so therefore are unable to make it to an SCS because they just, yeah. So it was very interesting to hear their perspectives, and they want to stay safe, they want to stay alive, they're trying to get through their substance use issues, and so those are the kind of the gaps that we've been able to take care of and support. Really good
Mm-hmm.
question.
Thanks, Chiram. Well, what I'll do our formal wrap up now, just to conclude, and then we can stop the recording and have some candid conversation. So just for the sake of the recording here, I'll pop back to my slides for a moment and um, I want to let folks know that we do record the events again, and you can find the event recordings on our website. So if you would like to share this event recording with others, you can share the recording. It'll be posted on our website within the next couple days. Shimmerum will post in the chat box where you can find the recordings on our website. Please feel free to circulate this recording to those in your networks. You know, this is a phenomenal service. We'd love to help highlight the service and the great work they do and the excellent model of community-based research that they have. We'd love for folks to stay in touch with us at CBR Canada as well. If you're not already signed up to our e-news, you can sign up for our e-newsletter online. Signing up for e-news means you'll hear about our upcoming training opportunities, upcoming webinars, workshops, opportunities for community-based research across Canada, and so on. And we'd love for folks to join us at our next event. As I mentioned, our fall series, we're celebrating the award winners and the nominees of our Community-Based Research Excellence Award. So our October event is going to be a bilingual event. It will be presented in French with simultaneous translation to English using the Zoom AI captions. And the presenter for the October event is going to be the winner of the Emerging Researcher Award, presenting about the MVF Telehealth Fall Prevention Program, a perspective on health equity. Le programme de télésanté en prévention des chutes MVF, une perspective d'équipe en matière de santé. So it's going to be a fascinating presentation. Once again, a very innovative health service that came out of a community-based research project. So we'd love for you to join us at that event. Again, it will be presented in French, but we will have translation to English using our Zoom captions. So Anglophones, more than welcome. It's a rare opportunity to hear about some fantastic Francophone research that's happened that doesn't always get translated to English-speaking parts of our country. So thank you so much, everyone, for joining us today. Thank you to Dr. Ghosh, who was able to join us and present. Thank you to everyone. And Monty, you've done a great job acknowledging everyone on your team who's been a part of making this project a success. So thank you, everyone. We hope to see you at future CBR Canada events. And I'm just going to stop the recording now.